Here we are, and the topic is expanding endotherapy options in early GI cancer. And I think often revolutions come in small steps, but I think this is really a revolution. And I think in the future we will have much more to do with early cancers. There are some principles if it comes to surgery and finally endoscopy about tumor resection. It should be an environment where resection alone is sufficient, so no distant metastases, etc. We, of course, like in surgery, we have to go alongside with complete resection, so-called R0, although in endoscopy the margins are narrow and there's no real definition what R0 is. Is it 1,000 micrometers, 500, 150, whatsoever? So we lack this information. And of course, we have to watch out for tumor biology with regards to the metastatic potential. And of course, at the end, also the risk of therapy should be taken into account. And this is, of course, mortality, but also, especially if it comes to comparison with surgery, morbidity, which can be significant. So these are the two facts which have to be balanced against each other. The tumor biology, the risks of the tumor and the risks of the therapy, or whether we allow the tumor to kill the patient or the therapist, the surgeon, to kill the patient. And even if this sounds banal, it's interesting that I think in most countries we rather allow the therapist to kill the patient than the tumor to kill the patient. And this is what I would like to explain a little bit in this talk. So we all have our guidelines, and we are, as endoscopists, only allowed with superficial melanoma of the GI tract here, the upper GI tract. These are the established criteria: mucosal, a certain grading, absence of lymphovascular infiltration, and of course R0. Then it's called low risk, and there is some assumption that this corresponds to a lymph node risk of less than 3%. And therefore we can excavate the tumor by various means. In the colorectum, one step down, there's a slight difference than at least in the international definition. The cancer definition starts with submucosal infiltration, so that's the only difference. The rest seems to be the same. We have techniques. You all know it started with the ingenious technique of CAP EMR, where we have various devices nowadays, which I don't want to go into the detail. We have a limited size of the resection specimen, so if we do larger areas, we have to do it piece by piece, which the Japanese named piecemeal, although it doesn't have much to do with a meal. If you do that, of course, you can cover large areas, as you can see here in the esophagus. But then another technique coming from Japan was based on the oncologic idea that we best do it as an en bloc resection. And you all know there is a huge number of knives and techniques to arrive at that stage. And here you see an example in the stomach, where you can resect this lesion en bloc, and then you have the specimen, and it seems to be easier for the histopathologist. And it was started in the Far East pretty early. In the West, it was pretty painful. I remember the first steps early in the 2000s. We were sweating, and the patient was bleeding, and so on. So this has developed quite a bit. And for example, in the esophagus and also elsewhere, the advent of the tunnel techniques inspired by Poem was really a step forward. So you left the tumor, you circumcised it, you went underneath with a scope, and then you pulled it upwards, and then you had to resect only the margins. So this converted a painful procedure to a tolerable one. And here you see the last cut, and you can do large areas in the esophagus, even by maybe less skilled Western endoscopists in 2 hours or so. Surprisingly, it seems to be forbidden to do randomized trials because there is just only one small randomized trial. That's not exactly true, but only one randomized trial. There are some appearing very soon in the colon, but there is a common belief that EMR is easier and more widespread, and ESD is more sophisticated and might have more complications. And we have tons of so-called meta-analysis, which I don't especially like because they stuff everything together and create a pseudo-evidence. Despite the lack of randomized trials, we tend to believe that ESD is indicated alongside these indications, maybe in squamous, because that's a tricky area, and maybe in the stomach. It's more complicated with Barrett and the colorectum. In Barrett we have a mixture of visible lesions, as you can see here, and the rest is the rest of the Barrett is a risk mucosa, and what we have been doing in the past years is a focal resection combined with ablation of the remaining Barrett esophagus, and the most published ablation method by far is RFA, but we have new kits on the block coming up like hybrid APC. APC is an old technique, but is maybe enforced by injection of fluid underneath. And from hot to cold, we also have cryotherapy for Barrett's esophagus recently. How we mix these techniques, we do not fully know. But maybe en bloc resection in Barrett is possible, but not so easy. So that's why we do this combination. Here you see the focal lesion in the Barrett, and the residual Barrett looks normal. So that's the final aim, which we have to achieve, that this looks like at the right side, the Barrett is gone and the lesion is gone. And then you have to, during follow-up, carefully inspect and watch out for recurrence. A few words about risks. These are well known. So we have perforation. It's rare. We have bleeding, post-interventional bleeding, and we might have strictures. And especially we have these strictures with complete ESD, like in Barrett's esophagus, because from an oncologic standpoint, it would be ideal. We take out the entire thing, the lesion and the Barrett, and off we go. And that's technically, with the tunnel technique, not so difficult, but we are really fighting with terrible strictures. There are also sometimes some unexpected complication, like that we're spreading tumor cells, which we could show in a small case series. After resecting the entire Barrett and injecting cortisone, we discovered very early recurrences in a few cases, and we found out that there are tumor cells in the instrumentation channel. So we are not only threatened by bugs, but also by tumor cells. That's rather easy to prevent. A few words about the colorectum. This is much different because they are mostly benign lesions. And as I said, the cancer definition starts with submucosal invasion, so that's submucosally invasive carcinoma. And the other problem is, do we really recognize reliably to which group this lesion belongs? Of course, it sounds logical. We do EMR for benign lesions and en bloc for lesions with some risk of malignancy. And the question is, how high should this risk be? How widely available is EMR versus ESD, etc.? And that's an ongoing discussion. So we know these lesions. The right side really looks malignant. With the left side, we are not so sure. We have heard that the cancer, if it occurs, it often sits in the bulky lesion, so you should take out within an EMR the bulky lesion separately, and all these kinds of things. At the end, if you look at the data, the rate of malignancy is not sky high, even in the suspicious lesions, so you have to weigh out the risk-benefit ratio of doing the more complicated procedure ESD, and this finally has to do also whether a country is able to manage to concentrate those cases in certain centers, or whether EMR should be out there widespread. And this is maybe the topic of a separate lecture. The recognition of cancer is not so good, although I think we have been told that the endoscopist's eye and now perhaps artificial intelligence are very good in seeing the histology deep down from the surface structure. I personally doubt it a little bit. These are data from the national Dutch program. So the Dutch are very thorough people. They're trained, they're endoscopists, and they should recognize the cancers. But here, in real life, it's not cases where there are cancers. In real life, the cancers are very rare. And among 3,600, there were 92 cancers, and they were missed in the majority of cases by the endoscopist. And that's just the effect of pretest likelihood and expectancy, etc. So it's still tough, although we have a lot of sophisticated devices for ESD in the future with second arms and robots and so on, and we will see whether this makes our lives easier or more complicated. This device has been largely published, a full thickness resection of cancers. You can do that. The publications are in mixture of indications. The R0 rate is variable. And again, whether this makes sense depends on tumor biology or how far you are allowed to go. And there are more devices to come. They are available like, simple through the scope suture techniques, less clumsy than the previous ones like the X-Tac by Apollo, now Boston, and a double clip by Microtech, licensed in some countries, not in Europe yet. So this will make the performance of transmural resection a little bit easier, because if you intentionally create a hole, the closure with conventional clips was possible, but was always a kind of a sweaty adventure. And there are other techniques coming up, like this from Leon Moons and Barbara Bastiaansen from the Netherlands, the endoscopic intermuscular dissection. In the rectum, you can go deeper. We know this from the surgical literature, and this is another very interesting technique. So at the end, this is the status quo, and the question is, what's coming next? What's the challenge? So let's go back to this one, the low-risk story. And especially if you look into the literature, here's the colon, here's the upper GI tract. There are some data from the colon, but in the esophagus, there are very little data. Actually, I think this low risk level comes from Japan and gastric cancer. And our Japanese friends are very cautious, and I think low risk means sort of zero. And the assumption is that it has to be balanced against surgical mortality, which is also very low, but I think in some areas it's not true, not to speak about morbidity. So at the end, we have a level with a zero lymph node risk, whereas, let's say, in the esophagus, the risk is 10%. So the primary balance, I think, is not very good, and we could perhaps become more courageous. And again, a lot of the worldwide evidence of endoscopy comes, bleeding evidence comes from Hong Kong, but a lot of other evidence comes from the Netherlands, and this is a maybe methodologically not brilliant, but very, very interesting retrospective analysis of 230 T1B cancers. And they were surgically resected, and they correlated it with the lymph node risk. So it's almost not quite the first, but it's almost the first study with a very differentiated criteria. And there were quite some surprises. First of all, G3 wasn't a risk factor. And then SM1, as you can see, had a very low risk, even SM2. And it only became very dangerous with lymphovascular infiltration and also with tumor site. And the same seems to happen. There is a separate lecture later on about the paradigm change with T1 cancers. And again, this is a large series from Sweden. So there was no risk with grading and SM depth, and there was risk with the mucinous type, younger age, and again, the lymphovascular infiltration. And this is a similar meta-analysis compilation of all the data. Here, the grading played a role and also lymphovascular, but not the depth of infiltration. So in the future, I think we can be more brave, and there are maybe many other options. What do we do with the high-risk lesions? First of all, maybe change the definition what a high-risk lesion is. But there are various other options. So could we do pretreatment, lymph node sampling, et cetera, et cetera? We published a small series on laparoscopic lymph node sampling. This was not the first one. A very small number of cases, so no conclusion about oncology, but it's possible. And in the meantime, we have now 45 cases, so usually the surgeon gets a lymph node number between 20 and 30, which is substantial, and I think it can be used as a risk assessment. And there's also an interesting study from Japan to add radiochemotherapy to squamous cell cancer, very risky cancer. First of all, even in Japan, all these cases were selected on an endoscopic basis. Even in Japan, these 176 patients turned out to be 74 T1A. So even in Japan, it might not always be possible to see what it is. But that's what the main focus of the study. These were the high-risk lesions with L1, T1B, etc., and with some kind of radiochemotherapy light with less radiation, the mortality and recurrence rate was, I think, tolerable. So I think what are we going to do? I think we should redefine the risk criteria. We can do a little bit more. Having said that, if we now treat deeper lesions, ESD is not the only way to go, so we could arrive at more aggressive resection techniques. Additional therapy comes into play, and avoidance of major surgery, minimization of trauma, less morbidity is the way. So if we wildly speculate, maybe T2 cancer can be downstage to T1 cancer, and if there's local recurrence, there are already data that these can be resected endoscopically. Or if there's incomplete response, then maybe the endoscopists can come into the game. So this is a long list we have to work on in the future, and it holds great promise. And I think we have to work hard, and please do proper studies, not only case series and meta-analysis, and then we can honor Don Wilson with really progress in that area. Thank you very much.